Welcome to the City Hospital Path Lab. My name's Dr. Babe, and this is my assistant Josh. Today, we will be trimming or grossing a breast wide local excision specimen. Please note that this specimen was originally received in the department yesterday, at which point, as per standard protocol, it was inked for orientation and replaced into formalin for overnight fixation. This is standard procedure for all wide local excision and mastectomy specimens. In addition, further incisions are made at the point of receipt in larger wide local excisions and mastectomy specimens. The reason for this is to enable further penetration of tumour tissues by the overnight fixation process. Okay, so we will start now. So initially we just follow standard patient identification protocols. And here you can make out the basic tools of the trade. Believe it or not, this is actually a clean work surface. But obviously it's been used many dozens of times, hence it's got some just some wear and tear. These are our so-called macro blocks, which produce large-sized slides, and these are our standard tissue blocks, which produce the standard-sized glass slide. Here I'm just checking the orientation of the specimen, and I might just try and freeze on that for you. There. So, this is of course a wide local excision. A different type of specimen to a mastectomy. Now, you'll notice, or you will recall, that Mehboob and Sadaf placed 2 sutures into their mastectomy specimens. That's a standard practice for mastectomies. The long suture denoting the lateral border of the mastectomy, and the short suture denoting the superior border. There are 3 sutures present here. There's one which is partially hidden or obscured by my glove, which is the short superior suture. Here you can see the longest orientation suture, which denotes the lateral border, and here is the middle-sized or medium suture, which denotes the medial border of this wide local excision. Having 3 sutures in place, in addition in this case to the skin, although most wide local excisions don't come with skin, keep that in mind. Having the 3 sutures and the skin in place allows us to very accurately map the specimen that we've received and orientate it using 6 sides of a cube, or of what is theoretically a cube or a cuboid. Then we use 6 different colours of ink to enable us to accurately map those margins. Once we've done that, we can then remove the orientation sutures. In our lab, the inking process is carried out by the science technicians. So before the pathologist even gets to the table, the inking should already have been done. We simply double check it. Here I'm just detaching the sutures that are no longer necessary. So wide local excisions can be trimmed in different ways, but far and away the most common approach is what we call bread slicing, which, as you can visualize, is akin to slicing a loaf of bread from one end to the other into multiple transverse sections. And you can immediately see in the second slice I've made, the first slice was the posterior end, which we mark in yellow. So we're going from posterior to anterior. And starting from the second slice onwards, you can see the lesion there, quite very nicely defined as this ovoid, rounded, white mass. Okay, it's not a spiculate lesion. I would describe this as a well-defined, rounded mass. And it contrasts quite brilliantly against the normal fibro-fatty tissue of the breast in the background there. And by this point, by slice number 5, the lesion has gone. What we're left with is just the fixed fibro-fatty tissue with some fibrous strands. So when we're slicing through the specimen, we use a combination of visualization and palpation to locate any discrete lesions. In addition to mass lesions, we can pick up calcifications by palpation alone, and indeed by the noise that the knife makes as it cuts through a calcified area. So particularly useful in identifying DCIS in mastectomies. So as you can see, we have a total of 10 slices, which I will number. The art of pathology is based on two things, really. Well, three things. The most obvious of those is obviously the microscopic examination, but before you reach that point, a good pathologist will be well orientated at all times, and they will localize their lesion at all times. So in order to remain well orientated and well localized with respect to the lesion, one needs to measure accurately, one needs to document accurately, and simple things like numbering slices and pointing out in your macro description in which slices the actual lesion itself is present. So delineating the lesion. At this point, I will measure the lesion in 3 dimensions. That is correct, but not in every lab. In the UK, there is a transition being made to give the biomedical scientists greater responsibility with grossing simple wide local excisions and simple mastectomies. I personally support this. I think with the right level of training, the biomedical scientists, so these are individuals who've done a biomedical sciences qualification, which is 3 to 4 years as a bachelor's type qualification. And so in addition to their usual lab-based responsibilities, they are now taking on greater responsibility on the trimming bench. So they've always inked, they've always weighed the specimen and prepared it for us, but now we're starting to allow them to do these simple wide local excisions where you slice from one end to the other, measure the lesion, and process it in appropriate blocks. So the transition is being made. Not in our lab yet, but certainly in some other labs. So as well as measuring the lesion in 3 dimensions, I will at this point record my macroscopic measurement of the margins. So there are 6 margins in total in a wide local excision. Those of you who are keenly observing will have come to realize that I can measure 4 of those margins directly, and indeed not just margins, but dimensions of the lesion. 2 of those margins will be estimated. Those will be the end margins. So the posterior margin and the anterior margin. Now I can see that the thickness of each of these slices gives me a minimum clearance of 10 millimeters from the anterior margin. So that's how I'll document it. It's going to be more than 10 millimeters clear of the anterior margin. The posterior margin is closer, because this slice that I took here, within which no tumor was identified, is probably about 3 to 4 millimeters. So for that reason, I'll estimate the posterior margin at 3 to 4 millimeters. I can make more accurate measurements using step leveling through that particular slice of tissue, okay, in the z-axis. That is perhaps, if it's not clear, I can explain it in greater detail later. But I'm talking about measuring a margin through the thickness of a slice. And you only do that when it's necessary, for example, when the margin is quite close to one of the end margin, one of the end slices. The other 4 margins are all clearly visible in these blocks here. This one is quite clear. These 3 are quite close. Okay. So that brings to an end this video part of the demonstration.